as chairman of the education committee, my duty was to find a country in an emerging area of the world and find one that didn't have a Department of Endodontics and actually start a Department of Endodontics. And the first project we had was in Fiji in the South Pacific. And that was my predecessor. He got to make several trips to Fiji, which is a nice place to go to. Nice beaches there. When it became my turn, they said, well, we don't know of any endodontic departments in Africa. And I was to research that. So I found out that there were no endodontic departments between Egypt in the north of Africa and South Africa all the way in the south. So that was my job. I identified somebody in Nigeria, and actually last week they opened the first Department of Endodontics in Africa. So we're doing some great things in the world. Maybe even during the break or sometime if we have time, I could show you some of the pictures of what's happening in Africa. Africa is not as technologically advanced as you are here. I'm amazed at some of the technology you have, which surpasses even what we have in this new building, because I think what happens is we get so bored with it that we don't pay attention to it. This is our new school. It's 6 floors. Our offices are right up here on the 6th floor. This is where the dean is, right over here. And he put me next to his office, I think because he wants to keep an eye on me. So I told him I put plaster over the hole in the wall that he used to spy on me. But our offices are up here. Our endodontic clinic is down here. So we have a lot of running to do. A lot of this was decided before I ever got there 3.5 years ago. And as you say, I used to be in Florida. I was chairman of the department there. We started the school there, a brand new school. And then I was about to retire. And this school got in touch with me and just made me an exciting offer that I couldn't refuse because I just love being with students so much. And I know your faculty here love it. You're all excited. I know you can't wait for the new school. As a matter of fact, our new school took a lot longer than yours. I heard about what went on for more than 10 years while they were trying to get the money from the legislature. And I heard from alumni who said they were promised they're going to be the first students in the new school. And then it was years after they graduated before the new school was finally built. So you're well on your way, and congratulations, and I can't wait to see it. I'd like to thank everybody that's helped me with any presentations. And you'll see a lot of names on some of the radiographs, some of the x-rays, because if somebody gives me some material, I like to include it and like to give them credit. Alex Fleury is someone originally from Brazil, from Rio, and I had heard him speak, and he's a microbiologist. He has his master's in microbiology as well as an endodontist. So I brought him up to Nova, and then he left Nova, and I got him a job at Baylor, and now he's in private practice. This is the symbol of the Miami Dolphins. I know when I was here last time, a lot of people were very familiar with American football, but if you're not, they had their training facility right next door to our dental school. So that's how I got involved with them. Plus I did a lot of work in trauma and spoke to the Sports Dentistry Association. Just before I came here on Tuesday, I was speaking to somebody from the University of Houston. They have a sports program, big football team, and now we're going to start a sports dentistry program at our school, and we're going to be doing the dental work for their teams. the mouth guards. That to me is part of endodontics. And it's part of something you could all do. Maybe we'll talk about that more tomorrow when we talk about trauma. Today we're going to be talking about endodontic emergencies. And I'm going to try to keep this fairly basic. I know most of you, or if not all of you, are still pre-doctoral students. With our graduate students, we get into a lot more depth, into a lot more of biology, why things are working, even going through the inflammatory mediators that are taking place. But right now, you have to know what to do when a patient comes in. So there are a couple of types of emergencies that we have in endodontics. One is the toothache, and the other is trauma. So today we're just going to be talking about the toothache. Okay, there are 3 phases of emergency endodontic care, and the most important is diagnosis. It's not what you do, it's what you find out is causing the problem. Then you could easily know what to do. So the second part is the treatment. The third part is the aftercare. And we're going to go through all of these as we talk today. Okay, let's talk a little bit about diagnosis. Maybe some of the old timers here remember Columbo. I see some smiles in the front row. Does anybody know who Columbo is back there? Okay, I see. Yeah, I won't say any more. I love that. It was a television show, and he was a detective. And he would always make believe he really did know what was going on, but always ask the right questions. And I always loved the show because he was able to find out what's important by asking the right questions. So that's part of what you have to do, is ask the right questions. Diagnosis is not simple, and please don't think it is. We're going to try to simplify what kind of treatment you're going to be doing. But the diagnosis part is the tough part. And no matter how computerized you are, computers can't do the diagnosis for you. Not yet, maybe someday they will, but they can't yet. Maybe someday you'll be able to plug a lead onto the patient and it'll tell you what's happening. Okay, so we're going to have to do a lot of thinking. You're going to have to be an astute clinician. You're going to have scientific knowledge, and that's where we get into the basics of what's happening, the biology of it. We're going to go through that today a little bit, but very lightly. Dr. Bocaux is going to get into more histology and stuff like that later, but not me. Some of it is intuition and an inquisitive sense, and of course, clinical experience comes into this. So, I highlighted inquisitive sense because that's where Columbo comes in. So we're going to talk a little bit about this. Here's a patient that came in, and you can see sometimes I'll have people's names down here. Manish Gurala was one of my residents at Nova. He was a fantastic student, fantastic endodontist. He was actually from England and came over to get American training. And during his 2 years, because we had a 2-year program, they changed the rules on him. And they said you can't be an endodontist in England unless you have 3 years and a master's program. And I wrote to several of the people, Tony Hoskinson, who was on the board at the time, that I knew through IFIA, and we couldn't get it changed for him. So he stayed an extra year, did a master's in education, which they accepted, and just when he was about ready to get his license back in England, he happened to meet a girl in Florida. And we have a very international student body, both in Florida and in Houston. So Manish is originally from India. He grew up in England and now doing his training at Florida. His wife was born in Vietnam, grew up in France, and also was in Florida. The two of them said, okay, let's get married. He said, great, I'm ready to go back to England. She said, there's no way that I am going to live in England. I'm from France. So he said, there's no way I'm going to learn how to speak French. So what they did is they stayed in the United States, and they're in Texas. So his extra year to go back to England actually landed him in Texas, of all places. And now he's right down the street from the school. So I get to see him a lot. This patient came in. Chief complaint was, I have a toothache. Well, now you have to question him. Manish took a look and saw that lesion up there and said, aha, I see the tooth. There's a bicuspid. We have to do endodontics because there's an abscess. But then somebody else said, look at this. There's another lesion there. Maybe it's periodontal. Maybe you have to take the tooth out. Or maybe it's a lateral canal. Then another one of the students came along and said, oh, look at the molar. That abscess looks bigger than the other one. I think the pain is coming from the molar. Nobody asked the patient really what his chief complaint is, except that it hurts. And then finally somebody said, when does it hurt? And he said, it hurts when I drink something cold. Okay? Now, as we'll talk about later, if it hurts when the patient drinks something cold, it's not coming from an abscess. It can't be coming from here, it can't be coming from here, because you're talking about a non-vital pulp. Okay? Hopefully all of you know about a non-vital pulp. So, you have to look further, and with all these abscesses, there's a big cavity here. And all that was needed in this case is to excavate that decay, put in a ZOE filling or an IRM, I don't know what they used at the time, and the patient was comfortable. The patient didn't have any pain when he drank anything hot. That's all that was needed. So, part of what we're going to do today is try to find out what we have to do to find out what the emergency is about. You don't want to spend a lot of time working on these abscesses and have the patient go home and then come back to you and say, I'm still having the same pain I had before. Okay, here's another case. Steve Cohen, in his textbook, many years ago, not the latest edition, gave steps for determining a correct diagnosis. You have to assemble all the available data. You have to look at everything that's there, which means, like we just talked about, find out what the chief complaint is. Find out about the medical and dental history, what's been done before, because that makes a big difference. How long has this condition been going on? Is it truly an emergency? Or has it been going on for 2 years and now the patient feels, well, let's come on in. And then you're going to have to do a bunch of tests, and we're going to talk about those. We're going to have to use a systemic use of the right tools. And the right tools is more of what's up here than what's down here that you're doing. There are a lot of tools you could use, but you have to be able to know how to use it. By the way, speaking of tools, I just found out that you just got your cone beam, the limited focus cone beam. We've had ours now for about a year in the endodontic clinic, and it is a fabulous adjunct, and you're going to have lots of fun with it. If I knew you had yours, I would have, like I told you last night, I would have brought a whole bunch of cone beam radiographs. I don't know how many of you are used to looking at them, but we have found out a lot of things using the cone beam that we didn't know before. For instance, resorptions. Now we could turn the tooth in 3 dimensions and see exactly where the resorption is. Some resorptions that look like they were internal are actually external. And maybe they're on the palatal surface, because we just had one of those and I'm going to be treating her in about 2 weeks. It's a dentist that I know actually has some resorption. We found extra canals that we couldn't see with our radiographs. So you're going to have fun with that. Okay, interpretation of the data. What data is really relevant? You have to talk to the patient and find out what the problem is. This patient came in to the emergency clinic, and right away, an oral surgeon saw the patient. And that's what the oral surgeon saw, right? Oral surgeons see impacted wisdom teeth. They want to take out the wisdom tooth. That wouldn't have gotten rid of the patient's pain. You have to talk to the patient and find out what's really happening. You have to get a working diagnosis, and you have to be open in your mind for further input. So the oral surgeon was asked, what about this? And it turns out that that was the culprit. That's why the patient was having the pain, was because of one of my residents did this, and that impacted wisdom tooth is still there. That's not giving the patient pain at all. But he almost had it out, and he still would have had his pain. By the way, I'm not blaming oral surgeons, okay? They are fine. We make mistakes sometimes too. You know, we look at something, we say it's a root canal, and it isn't always, like that first case. Okay, here's another interesting case. This patient came in. Patient was having pain on this tooth, on the first molar. And the patient had endodontic treatment on that tooth by an endodontist 2 months before. And he said, I keep having pain to cold, and everybody tells me I'm crazy. And I looked at this tooth, and I know the endodontist who treated him. He's a very fine endodontist. And I took several radiographs, and everything looks like it's obturated perfectly. There should be no pulp tissue in that tooth to be able to feel cold, because cold is coming from vital tissue. So I look around, and what do we see? We see an open margin here. We see what looks like maybe a thickening of the ligament over here. And I say, your pain has to be coming from that other tooth. He says, Doc, it's not. So we go ahead and we test it, and what do I find? There was a third mesial canal. And I left out some of the in-between. He constantly felt it on number 9. Do you use the 1 to 32? Okay. He constantly felt it on number 19 whenever I tested it. Maybe there's an open margin here. Maybe there's a little perio here. When I opened the tooth, sure enough, between the gutta percha, the mesiobuccal and the mesiolingual, there was this pink dot that I could see with the microscope. And that was where his pain to cold was coming from. And once we took care of that, his pain was gone. So sometimes you have to investigate a little bit. And here's a picture. Let's see. Here you can see 3 canals in the mesial. And we've been finding those more and more. When we first got the cone beam, we've been looking at canals, and there have been some articles written in the Journal of Endodontics of extra canals being found. And of course, if you go back to a lot of the research done many, many years ago with putting India ink in the canals and looking at how many there are and what sort of shapes, it's amazing what you would find. Okay, here's another case just to get you thinking. This is a case that I used to use when I was doing the testing for the Board of Endodontics. As a matter of fact, the Board of Endodontics had so many applicants this year, they called some of us old guys back to help them out. So I was testing again, which was interesting. It's been a long time. Anyway, this is one of the cases I used back then. And we'd give the candidate a sheet of what the patient's medical history was, what the symptoms were, and they had to ask us questions, and by asking us questions, eventually come up with a diagnosis and a treatment plan. Okay, so here's what we had. We had a patient who had endodontic treatment done by his general dentist. He kept having a sort of feeling down around the apex there, and it was sort of a crumbly or a crunchy feeling. And when you ran your finger over it, it was a little crunchy down in this area here. When I called the dentist to ask him why he did the endodontics, what his diagnosis was the tooth vital, was the tooth not vital, his records had nothing. He didn't remember. Okay? So, make sure you keep good records. That's number one. By the way, we were talking this morning about records and getting bacteria on the paper. We have no more paper records at University of Texas. Everything is on the computer. So we're not touching paper and passing along any germs. And then we have a cover that goes over the keyboard that we take off and put another cover on. Anyway, I'm digressing. So, patient had this endodontic treatment, nothing has changed. One of the things that this patient had was a history of prostate cancer. And it's amazing how many of the candidates, probably at least 2/3 of them, said they would retreat these endodontic fillings because they didn't like the way they were filled. Nobody talked about his prostate cancer. I went in there and did surgery, and we sent it out for biopsy, and they did a PSA test on the lesion that I sent for biopsy, and it was prostate cancer. So you have to do your diagnosis very thoroughly, be like Columbo, ask a lot of questions. These candidates didn't ask us any questions about his prostate cancer. And it doesn't have to be prostate cancer. Breast cancer could also metastasize to the jaw. There are a lot of things that can metastasize to the jaw. We're not going to get into that right now. There are a lot of conditions that could mimic a toothache. Cardiac insufficiency is one of them. Somebody could be having a terrific toothache and it's really a heart attack. Don't jump in and do root canal until you've done all your tests. So if that's the only message I leave to you, remember it and we would have done well. Okay, now we're going to go through the clinical exam and talk about this a little bit. How do you do an examination? The important thing that everybody does is test with cold. That's usually the thing that patients will complain about the most, is I have pain when I drink something too cold. Some people would take cold water, put it in a syringe, but if you're going to do that properly, you really have to do it with a rubber dam on, which means you have to do several teeth, and that means taking the rubber dam off and putting the rubber dam on, and taking it off and putting it on. So it's not really a good way to be testing in your office when you get to the to have an office. Some people used to use an ice pencil. This is what I was taught when I was in dental school. We would take a carpule, an anesthesia carpule that was used, empty it out, take the plunger out, and fill it with water. And then take that out and test one tooth at a time. The only problem with that, we found, is that the ice would melt. And if the ice melted and that cold water touched the tooth next to it or the tooth below it, sometimes that can give you a false reading. So we got away from ice pencils. Some people decided on carbon dioxide. That's dry ice, and there's a gadget for it. It's a big tank. A lot of people like it because it's very cold. It's 75 degrees below 0 centigrade. There are a couple of problems with that. Dry ice evaporates, as you could see here. We had somebody at Nova that really believed in the dry ice, and we had one of these units here, and one of the students was testing with the dry ice, and it got thin like that and broke off and burned the patient's lip. It's so cold it's actually going to burn. So that's when we said, okay, we're going to stop doing that. There's too much liability. It gives you a good reading. You'll look at the literature, and the literature will say this is a good way to test for it, but keep away from that. What we do is buy a refrigerant. There are many of them on the market. You probably have some in the endodontic clinic, either Endo Ice or Frigident or ethyl chloride. It's not as cold as the dry ice, but it's colder than regular ice, and it evaporates fast enough that you could put it on a little piece of cotton or on one of these little swabs that we use now and actually touch one tooth at a time and see where the cold is coming from. With any of these tests, start with something further away from the tooth that you suspect it is. So if you suspect that the patient is really having pain, say on this canine over here, start with the central, then go to the lateral, then go to the canine. So the patient gets used to feeling what normal is, plus it may be a different tooth. And then when you get there, don't put it on there and hold it on. Let the patient just tell you, yes, I feel it. And as soon as they tell you they feel it, take it off. And we'll go over what all these things mean. But heat is something that's tougher to test, and that's why a lot of people don't test it in endodontics. But you should, because it's going to give you valuable information, as we'll see later. So you could do hot water in a syringe, which is very similar to cold water in a syringe, where you put the rubber dam on. You could use a rubber wheel and vibrate that, but that could also get onto the patient's tongue or lip. But some of the old timers still use those rubber wheels to generate some heat. You could use some hot compound. I didn't even know that you still had hot compound around, and I was asking one of my prosthodontic friends, and they said, oh yeah, we still use compound for certain things. I don't know if you use it here. Some schools don't use it, but you could always touch the tooth with a little bit of hot compound and go one tooth at a time. Or you could use hot gutta percha. And as endodontists, we have plenty of gutta percha around. So you could take a stick of gutta percha like that, or even better, if you have one of your heat carriers, such as a System B or Touch and Heat. I almost forgot the name of it, the Touch and Heat. A lot of these come with special tips to put the gutta percha on, and it spreads the heat out. And you could turn it up to whatever temperature you want and be able to touch one tooth at a time and see where the patient's pain is coming from. Now, when you're doing either hot or cold, you have to make sure that you're touching tooth. and that you're not touching a crown or a veneer, because it just doesn't work there. Okay, a little bit about percussion. Dentists love to take the back of a mirror and start banging on teeth. Please, for your patient's sake, don't do that. You want to keep your patience. If a patient is complaining about pain when they bite down, don't take that mirror and start really banging. Like I said, start with the other teeth and then gently go over and tap it very lightly. If a patient is having pain with percussion, they'll feel it with just the slightest tap. Okay? Now, you could tap it vertically like that, or you could tap it horizontally. And does anybody know what you're going to find out with those two things? You're going to find out different information. If you tap it vertically, you're going to find out if there's inflammation around the apex, periodontal ligament, because the tooth is up here and you're hitting it down here, and this is where the inflammation is. Now, if you tap it from the side horizontally, it's not going to affect it so much up here. Sometimes a patient won't even feel that. But sometimes a patient will feel that and they won't feel it up top. Sometimes a patient will come back after endodontic treatment and say, "Doc, it hurts when I tap it like this." What that's indicating is that there's a lateral canal up there. There's a canal coming out sideways, and there's inflammation at the side of the tooth. And if it's happened after a good obturation, after endodontics, it'll usually go away within a few weeks, and you can assure the patient that that's okay. And then if you want to scare the patient a little bit, you could say, and if it's not, we could always go in there surgically and cut it out. But no, that's too mean. Just reassure them that it's going to be okay. So that's what lateral tapping means. So if they feel it when you tap laterally and not vertically, and they haven't had endodontic treatment yet, it could be that it's just starting and it hit a lateral canal and there's inflammation there. So it could still be that they need endodontic treatment. Okay, palpation. Palpation is very important to find out if somebody has an abscess or not. And when you palpate, you have to palpate up around the apex of the tooth, not down here. You want to feel along the bone where the apices are, and if a patient is having an abscess from a tooth, even if it's not showing on the radiograph, they're going to feel it when you touch up there, because an abscess may be forming, it hasn't broken through the cortical plate, and it has to break through the cortical plate for you to see it radiographically. So you press up there, and you may have an expanded cortical plate, and the patient will be able to tell you that's it, and you'll be able to feel what tooth it is. So do the palpation. Here's a patient that kept having pain on palpation over this bicuspid. The endodontic treatment was done, and it looks like it was done very well. But there's a lesion up there. So we decided to go in surgically, and what we found out is that there's a big opening into the sinus. Now, one of the things that we asked the patient before we even started was about sinus pain, if the patient ever felt that. And they said, I've had sinus for years. Well, we thought it was just an endodontic lesion. We went in there surgically, and especially with the microscope, we could see that opening into the sinus. And just to show you what we do with something like that, we put a membrane behind the opening, and we're able to put a graft in there, in this case a calcium sulfate graft, and then close it up. And this patient came back, and what the chief complaint wasn't the sinus problem. The chief complaint was just the pain when they touched at the top of the tooth. And the patient came back and said they're sinus pain is gone for the first time in years. So what we're finding now, especially with the cone beam, we could see a lot of these sinus openings and know that they're really openings into the sinuses. We're finding more and more communication between sinuses and the teeth, more sinus problems being caused by the teeth. And last week, I met with the chairman of, they changed the name, otorhinolaryngology, which is ENT, at the University of Texas, and we're going to start some joint programs together with the endodontic residents and the ENT residents, because we have to learn more about the sinuses when we do endodontic surgery, and they have to learn more about dentistry and what we're doing and what kind of symptoms are really tooth-related and not sinus-related. So that's a new program we're going to be starting, and it's all because of how much sinus problems we saw with the cone beam. Periodontal status. You have to check this out, because if you don't check out the periodontal status, you could be doing endodontic treatment and it may be for no reason. And you have to pulp test the tooth. In this case, it looks like a periodontal problem because look how much bone is destroyed here, but you want to know something? Can't probe it. Here's another, by the way, there was a lateral canal on that one. Here's a lesion that they thought was a periodontal lesion. They thought it was a lateral periodontal abscess. But I wasn't happy with that endodontic treatment. Look at this. This is supposed to be obturated and sealed all the way down to the apex. So we decided before they did any treatment periodontally, we would check this out endodontically, and this is what we found. See that? The cement came out the side, ended up not doing any periodontal surgery, and then that healed beautifully. So when you have something that's endo and perio, always do the endodontics first and see how that heals. Here's another one. It didn't probe, even though the endodontics was done. You could see there's some space here. There's a little bit of a lateral canal. But we decided to retreat that before anybody else went in there surgically. And sure enough, there's a big lateral canal, and we got that to heal. Okay, and now this is one. Years ago, we a few of us were doing an endo-perio Colleagues for Excellence. Do any of you get Colleagues for Excellence here? No. The AAE, the American Association of Endodontists, puts out something called Colleagues for Excellence, where we market it to the general dentist, and we send it once or twice a year to at least to all the general dentists, I think in the United States and Canada, and maybe other places if they're ADA members. So I did one on endo-perio years ago, and this is one of the cases that we published in there. We looked at this, and if a periodontist, I showed this to a whole bunch of periodontists, and they said, you got to take it out. Look at this. There's no bone here. You have to take the tooth out. The tooth was necrotic. There was a sinus tract. This is a tracing of the sinus tract, and that tracing was separate from the periodontal ligament. So went in and did the endodontics. This was 3 years later. Now look from here, from this bone loss to here. Now there's still a periodontal problem here, but this patient has had this tooth for 3 years. It was an endodontic problem. We carefully diagnosed this correctly. It doesn't always work out that way, but in this case, it worked out fine. Let's talk about electric pulp testing. There are a lot of people that say electric pulp testing is useless. I hope that's not what they're teaching you here. This is very important. It's part of the puzzle that you have to put together. You have to collect all this information and put a puzzle together. So, a few things about electric pulp testing. Number one, make sure it's working. I can't tell you how many students start pulp testing and say, all the teeth are non-vital. We're going to have to do 6 root canals. And of course they do it to the anterior teeth, because nowadays it's tough for us to get anterior teeth, at least in the States. So many general dentists do anterior teeth, and people take care of their teeth. They really don't need it as much. So they're ready to do those anteriors, and they'll share it between them. But make sure it's touching tooth structure. I've been fooled sometimes where I've tested a few teeth and I'm getting no response, and I look real carefully with the microscope and there was a beautiful veneer or composite done on the tooth. And in that case, try testing on the lingual. Okay, now if it's a porcelain crown, you're out of luck. It's tough to test it. The question comes up, where should you test it? Apically, or near the cusp tip, or even in the middle? A few years ago, I.B. Bender, I don't know if any of you know that name, but I.B. Bender was an endodontist who was one of the brilliant pioneers of endodontics, and he lived a long life. And when he was 93, he did a research project on this. 93, and he published a paper. By the way, he passed away, I think he was 97 when he passed away, because I was at his 95th birthday party. What he found out is that the cusp tip is the best place to test it, because at the cusp tip, you have more ramifications of the nerve endings. So you're better off testing at the cusp tip than you are around the cervical margin, which is different than what we were told years ago. And you have to use a conductor. And you see I have KY jelly up there. Endodontists do some funny research projects, especially the residents. And at Case Western Reserve, they did a study to find out what the best conductor was, because for years and years, everybody was using Sensodyne toothpaste. And it was just passed down from one generation to the next. Use Sensodyne toothpaste. Why? Nobody knew, but maybe because it was Sensodyne, it had something to do with sensitivity to the tooth. Well, after the study came out and they found out really the best is KY jelly, and it washes off easily, not the fancy stuff, just the plain stuff. We found out by asking people the reason they were using Sensodyne is because Block Drug Company, which used to own Sensodyne, gave out so many samples that dentists didn't know what to do with it. And that's the only reason they used it, because we had all those samples. Okay, so make sure you use a conductor on that. The important thing is that the most reliable thing you're going to find out is whether there's a response or no response. Don't worry so much about the numbers. It's good to put the numbers down, if nothing else, for legal reasons, just to prove that you did it, or to see if there's a change later on in 6 months. But no response is the most reliable. If a tooth is vital and you have a lesion there, don't jump in and do endodontics. Like that case with the prostate cancer. I'll bet you when that dentist went in and did that endodontic treatment, those teeth were vital. If the teeth are vital and there's a lesion, there's got to be some other reason for that lesion. So this is going to be important information that you're going to get from electric pulp testing. Matter of fact, I remember it was 1972. I was just out of the Air Force, working in private practice with an endodontist, and we had a case where nobody could find out what tooth was giving this patient a problem. They had kept doing root canal on the same tooth, and as a matter of fact, they even extracted one tooth because the surgeons did an apico on it and the patient was still having a problem. And I ended up doing pulp testing because that's what I was taught in school. And sure enough, it was coming from 2 teeth away from that. So here was this little kid, just in practice, and I found out something that the old timers just ignored. So do your pulp testing. There's a difference between vitality and sensitivity, and the Europeans like to point that out a lot. And I don't know how you feel about it here. The Europeans don't call it vitality, they call it sensitivity. Especially Jens Andresen in Denmark. He likes to call it sensitivity. A positive response to electric stimulation doesn't provide any information about the health or integrity of the pulp. You don't know what kind of circulation is going on in there. It just says there are sensory fibers, and the nerve fibers are the last fibers to die. So you could have a necrotic pulp and still be feeling it with an electric pulp tester. And one of the things that we're doing a research project on now at the University we're doing the laser Doppler flowmetry. We have a unit that's sensitive enough to use on teeth. We can't use it through crowns, but then again, you can't use an electric pulp tester through crowns either. And we're measuring, especially with trauma cases, whether we're getting different readings. And with the initial study that we did, we found a few trauma cases where we were getting negative readings with an electric pulp tester, which is not unusual right after trauma, but there was still circulation in the tooth. And the laser Doppler showed us that. So maybe you'll see some interesting results coming out of that. That's why we do research. Maybe you won't. There are other ways to do it, like the pulse oximetry, radioactive injections, but you're not going to do that. So other tests that you could do, some people like to do a test cavity if you can't find out where the pain is coming from. Now, a test cavity isn't going to help you if somebody's having pain to hot and cold, but if somebody is just having pain and you can't find out where it's coming from and you suspect a certain tooth, you could do a test cavity, which means drilling into the tooth without any anesthesia and seeing if the patient feels it. It's a little barbaric. Sometimes it's absolutely necessary if the patient continues to have pain and you can't find out where it's coming from. Another test that you could do is selective anesthesia. Selective anesthesia is a matter of if a patient's having constant pain, you anesthetize an area to see if that's where the pain is coming from, if their pain goes away. But you have to be careful. For instance, if a patient is having pain in the mandible, if you just go ahead and inject in the mandible, great, they'll get numb. You have no idea which one of those 8 teeth or so are causing the pain. So if they're having pain in the mandible, good thing to try is maybe a suspect tooth in the maxilla and do a couple of different injections with a very short-acting anesthetic like carbocaine. See if it goes away, and then when the carbocaine wears off, see if it comes back. But see if the patient's pain goes away. Maybe it's referred pain, which we didn't talk too much about. That could happen. It could be that you inject everything and the patient still has pain. So maybe it's not coming from a tooth. Maybe if it's a mandibular tooth that they're having pain on, maybe it's really a heart attack. So, try to do these things and be like Columbo and put all your tests down. And then there's also transillumination. Transillumination is a shiny light, and hopefully you have some of these fiber optic lights somewhere in the clinic. We had to dig them out, and especially after we moved, they got lost somewhere. But with transillumination, you could take a look at a tooth and see if the light is coming all the way through. Because if it stops like this is due to a fracture. If this tooth wasn't fractured, that light would come all the way through, and this would look pretty uniform all the way across. Okay? So transillumination is a great way to tell if there's a fracture or not. We're going to talk a little bit about pathology, but this is simplified. This afternoon, you'll get it complicated. This is just to give you an idea of what's happening in the pulp when you're doing all these tests, and maybe give you a sense of what you're looking for. Okay, before we even go into the pathology part of it, there are some things that I want to tell you ahead of time. And number one is the etiological factors of pulp disease. And there are a lot of different etiologies, whether you're talking about microbial because of caries or periodontal disease, trauma, whether it's a fracture or just a concussion, we'll talk about that tomorrow, or iatrogenic, which is your own doing. Marginal leakage is a big cause, but the only real cause of a pulp lesion is bacteria, right? Talking to microbiologists here. You cannot have a pulpal lesion, you cannot have endodontic disease without bacteria. No such thing. There was a study done back in the 60s by 3 people named Kakahashi, Stanley, and Fitzgerald. And that is the most read and the most quoted article in all of endodontic literature. And 2 years ago, we gave an award to Sam Kakahashi for his paper. And I was talking to him before we gave him the award, and he was flabbergasted because he never knew that anybody ever read his paper. He never knew how important it was. What they did, very basic research, they took 2 types of rats, notobiotic rats, which means no bacteria, and regular rats. The regular rats were exposed to the air, they were in cages. The notobiotic had special cages where the air was filtered, and you had to wear the gloves to do everything. Their food was sterilized. And what they did is they made pulp exposures in the molars of all these rats. And they found that the regular rats developed pulp lesions. They had necrosis. They had infection. The notobiotic rats, where there was no bacteria, not only did not have any infection and did not have any abscesses, but it actually healed. Dentin was formed over it because the body has a great potential for healing. And it's the bacteria that stops it from healing. So that article is quoted in every endodontic program throughout the world. So if you're going into endodontics as a specialty, know that article. Okay, we're going to start off with a whole bunch of drawings here, and I thank Dr. Andresen for these drawings. We've modified them a little bit, but these come from one of his textbooks. So when we have a little bit of decay in a tooth, there's a little bit of inflammation. You see those little red things up there? That's denoting little inflammation. Maybe the blood vessels are widening a little bit to try to relieve some of this inflammation. What happens here is you can get reactive or reparative or secondary or tertiary dentin, whatever you want to call it, right around that area. And usually this happens and it's asymptomatic. You're dealing with it every single day when you're cleaning out caries. This is what's happening. It's really a reversible pulpitis that's happening underneath that dentin. and that's why you're getting the repair. At this stage, probably the bacteria have not gotten into the pulp yet. Or if a few of them got in, the body could handle it. There were no symptoms with that. Next, we have caries that's going a little further. Okay? The pulp is reacting with more inflammation. And this could be chronic or acute. Sometimes you may have pain to cold. You may have pain to sweets. If a patient complains of pain to sweets, and that's the only complaint they have, it's decay. And if you clean out that decay and put in a restoration, their pain to sweets should go away. Okay? So pain to sweets is decay. It's usually reversible. Sometimes they could be feeling cold. Usually it's more of a sensitivity to cold. Okay? Right now, we're just dealing with an inflammation within the pulp that the body could still handle. Okay? So you don't need endodontic treatment for this. Next, the caries is going to progress more. And you're going to start to get a more severe inflammation. You could start getting spontaneous pain. And this is sort of a never land. You don't know what's good and what's bad. Do you do endodontics on a tooth like this, or do you not? It's sort of in between. The thing to do here is to clean out the decay, and if you don't have an exposure, if there's some dentin under it, do your restoration. Put a base in. I'm not going to tell the restorative people how to do your restorative because it's been a long time since I've done that, except for a temporary filling. But this could be reversible at this stage. Again, this is more likely to be an endodontic problem than the one before. This is something that you might be telling the patient, let's see how this does. If your pain continues, we're going to have to do endodontics, or if it gets worse. But many times, when you just have it with cold, it could be reversible. This is what I was looking for before. Takahashi, Stanley, and Fitzgerald. The bacteria have to get into the pulp in order to have a pulpal lesion. Inflammation itself won't do it. Okay? So if you're getting inflammation in here, and what type of bacteria are we dealing with? We're dealing with gram-negative bacteria, which means endotoxins. Okay? I try to keep this clinical, but if endotoxins get in and not bacteria, that could be reversible. Now, you're getting further along, okay? Now, you're getting bacteria into the pulp. So, you not only have the pain to cold, but you have pain to heat. Once you have pain to heat, it's irreversible. Patient has pain to heat, do the endodontic treatment. I'm not talking about sensitivity, I'm talking about pain to heat. Why do they have pain to heat? Glad you asked that. What happens here is the part of the tooth up in this area around here starts to become necrotic. It's like a micro abscess within the pulp chamber. So you probably have a lot of vital tissue up here, but still you have that abscess. Now what happens when you put heat on either a gas or a liquid? Remember Boyle's law from high school? It expands, okay? So you have the gas or the liquid within the tooth, liquefaction necrosis taking place, and you put heat on, it's going to expand. You might even have a patient coming into your office with a thermos of ice cold water because they found cold is the only thing that'll make them comfortable, because cold contracts that, and therefore they no longer have the pressure on the vital tissue that's up there. So you may not see any sort of lesion, but if a patient has pain to heat, the only thing that's going to help it is endodontic treatment. Okay, so remember that. It's irreversible. Also, what you may get, at this stage is inflammation of the periodontal ligament, because the inflammation goes up through those central arteries and venules, arterioles and venules. And they sort of bypass everything along the side, and the inflammation products get up to the periodontal ligament, inflame the periodontal ligament, and the patient may have pain when you tap on the tooth vertically without there being an abscess yet. Okay, now we're progressing further. What happens here? The pulp dies. It's necrotic. And it becomes asymptomatic. That's the patient who comes into you and says, "Doc, I've been having pain for weeks and weeks. I've been having pain to cold. I've been having pain to heat. I couldn't get an appointment with you, but I finally get the appointment with you and it's comfortable." You know, it's like my car. I can have this rattle that drives me crazy and I bring it in and it stops rattling. You're going to see that a lot in your office. This is probably the stage it's at. And this is where the electric pulp testing is going to help out, because you may find a tooth that doesn't respond to the electric pulp tester, even though they're not feeling pain to hot and cold anymore, and they're not yet really feeling pain to percussion. So that's a reason to go in there and do endodontic treatment. Plus, the tooth may discolor. Sometimes you'll see that the tooth is starting to get very gray. And what's the reason for that? I ask everybody here. What's happening is that the blood vessels are breaking down within this area. And when the blood vessels break down, the hemoglobin from the blood gets into the dentin and starts to corrode. It's iron. Hemoglobin is iron. And as it corrodes, you start to get a sort of grayish appearance. And that's why people will have this happen. Sometimes just doing the endodontic treatment will bleach it enough and get rid of that discoloration so that the patient will be very happy. Other times you might have to bleach it. Okay, then, picture what's happening. Now we're at the stage where hot and cold isn't going to tell us anything. The patient's not having any pain to hot and cold, but you have an abscess. Remember that first one I showed you? There were a bunch of abscess teeth up there, but that wasn't the major problem. But it does become a problem because you have an infection up there, and it should be treated. So you now have periradicular inflammation, not inflammation within the pulp, but up in the bone. And you have a periradicular periodontitis. That just means that around the end of the root, there's inflammation of that periodontal ligament. And it develops an abscess and maybe even a sinus tract. So sinus tracts can go a lot of different places. You know, they could come out to the buccal. They can go up to the sinus, like I showed you before. Or they can come to the palate. Every once in a while, you might even see a palatal lesion. Like I showed you that one that just went over to the periodontal ligament and set up a little abscess there. So if you look around and you see a sinus tract, if you see a sinus tract stoma, a lot of people call it a fistula. The official term is sinus tract, though. Trace it. Take a flexible gutta-percha point, put it in there, and take a radiograph so you can see what tooth it's coming from. Okay, and remember, necrotic tissue by itself is not antigenic enough to produce and maintain periradicular periodontitis. That's another word for an abscess. So you have to have infection in there. Martin Trope and Asker Sigurdsson used to both be at University of North Carolina. Trope is now in Philadelphia. They said there's a poor correlation between clinical symptomatology and pulpal and periapical histopathology, which means everything I told you is wrong. But I told you that so you could get sort of an understanding. As a matter of fact, with my residents, I have one of my favorite slides that I show them the first week of school, and it's a quote by an educator from years ago, and I forget the educator's name, but it says, information is changing so fast that 50% of what I'm telling you is going to be proven to be wrong. The problem is, I don't know what 50% it is. So that's happening very quickly in education, and especially in dental education. We've made attempts to try to diagnose the condition of the pulp according to signs and symptoms, and it has never really correlated. We can't really correlate the histology. Now, we might find different markers. What we're looking at now is inflammatory markers, like MMPs, to see if we could do a test and measure the MMPs, and maybe that'll tell us better what kind of condition it's in. So these are a lot of things that are coming up in the future. As far as classification of the pulp and periapical disease, like I said, there's a poor correlation, and these terms that I used, reversible and irreversible, are only clinical observation. So I'm saying that's my legal excuse at the bottom, that everything I told you is sort of wrong. I hope I'm not going to fall off here, but I'm trying to get to a spot where I could see this, because it's too small on here and too big on here. I know Dr. Alfaro is wondering, gee, if he falls, is there a legal liability? I'm trying to be careful. We're going to summarize the clinical pathology, everything we just talked about, into this one slide. And this is really what you need to know. Okay? You have two types of pulps, and when we talk about treatment, we're going to talk about different ways to treat these. So either the pulp is vital or it's non-vital. It's not the tooth that's vital or non-vital. You don't have a non-vital tooth. All these teeth are vital, even one with the non-vital pulp, because it has a healthy periodontal ligament around it. If it was a non-vital tooth, the body would exfoliate it. Okay? So that's why we could do endodontic treatment and still keep the tooth there. So, vital pulp, sensitivity to cold. If it's sensitive to cold, it could be reversible if you get to it in time. If it's pain to cold, it may be irreversible. Maybe. You know, you're somewhere in between. And if it's pain to heat, it's definitely irreversible. So with all those testing, that's what it comes down to. I could have given this whole lecture in about 7 minutes. Non-vital pulp, you will have no pain to temperature, no response to the electric pulp test, and you may have a radiographic lesion. See, here you probably won't have a radiographic lesion because there's still vital tissue up there. Here you may or may not, but it's still necrotic.
Yes. Sally, there is going to be a big change with the diagnosis with the cone beam with this radiographic lesion.
Yeah. What Dr. Mata just said is, with the cone beam, there's going to be a big change in us diagnosing the radiographic lesions. And you're right. Now I wish I had brought some of the cone beam images to show you. We had one case where the patient was having pain. We couldn't diagnose it at all. We suspected that there was necrosis, and we took a cone beam. It was a palatal root that tilted towards the buccal, and when you looked with the cone beam, you could see the lesion between the buccal and the palatal, but it didn't show up in a regular film because it just wasn't high enough. It was blocked out by the sinus and the malar process and everything else. And we said, it's obvious, it's right there. There's a big discussion now amongst endodontists and radiologists about when we should use the cone beam. Because there are some endodontists that think we should take a cone beam on every patient that comes in, because we don't know what we don't know. There are other radiologists and endodontists who say you have to have a reason for it. If you could diagnose it without the cone beam, then you shouldn't take the cone beam. The problem is sometimes we wait until there's a failure, until it's not successful, to first take the cone beam, and then we see something that we missed because we didn't see it there, even though we diagnosed it correctly. And I'm talking more about extra canals, fractures in teeth that we could see, just the one I told you about with the external resorption. You could see where it is, whether it's treatable, whether it's not. So we'll have to see how that pans out. Radiologists just came out with a new position paper saying that you shouldn't be taking them haphazardly. And of course, a radiologist should be reading it. But that's a whole, do we have any radiologists here? Okay. So I could talk about the radiologists. The radiologists just became a specialty, what, about maybe 5 years ago? And with the cone beam, they came out with a position that every cone beam should be read by a radiologist, otherwise you're legally liable if you miss something. And I not testified, but I talked to the AE leadership about this. If that's true, then every Panorex that we used to take should have been going to a radiologist. Every occlusal film should have been going to a radiologist. Every head and neck film that's taken by a medical radiologist should be going to an oral radiologist, because the physicians don't know how to read anything in the jaw. They say, we don't know anything about that. So yes, maybe theoretically there's some legal liability, but I think practically we know what's in our field better than anybody else. And if something looks suspicious, then you can get the opinion of a radiologist. But to have it routine, no, I think they're just trying to generate some business for themselves because they don't have enough.